Thank you very much. We're good? I think the sound is good. So in this talk, I know some people have come because of aphasia. I'm going to be talking about aphasia, but not really aphasia after strokes. So if there are questions about that at the end, I'm happy to speak about other aspects of aphasia. But what we did was, let's see if I can share my screen. Share. Okay. In thinking what would be most interest, I decided to make this more about aging and degenerative diseases of the brain because we are doing some very important research on a condition called progressive aphasia, which is a form of Alzheimer's disease. And I'm hoping that Shelley Solomon, wave Shelley, who's my coordinator in Montreal, will get some interest from people because we're looking for volunteers who are perfectly normal people over age 60 to come into our research. And we're trying to make sure the community knows, because there are people with progressive aphasia in the community who have been seen by doctors and told, you have progressive aphasia, there's nothing that can be done. And since we're doing experimental treatment, we need to reach out to find these people who are in the community. So if you know anyone with progressive aphasia, this is important information for them. So I'm going to be advancing my slide if it advances. And if it doesn't advance, let's see. Sure, let's see, I'm pointing there. It doesn't seem to want to advance for me. What do you think? I can advance from the computer. Try now. Oh, all right. Okay. Oops. All right, we're good. Okay, thank you. So you always have to put up showing who pays your bills, and these are my University of Toronto and the Canadian Institutes for Health Research and other funders who support me. And we do a lot of clinical trials in Toronto, so I receive support for this from many pharmaceutical groups, but that's not really relevant to this talk. So I'm going to spend a few minutes, because everybody asked this, talking about what people can do to prevent getting dementia. And because everyone asked this at every talk, so I thought I'll just put it in at the beginning. There's now been a lot of work on things people can do in their lifestyle to try and prevent them getting dementia when they get older. And there was something called the Lancet Commission, and it came up with a list of things, and these sort of 12 known lifestyle factors that can be changed and controlled. And this is something we publicize a lot in the community because there are things people can do. If you have a parent who had Alzheimer's disease or relatives, or you're concerned about it, these are sort of the list of things that people can do. First of all, stimulating your brain, getting more education and coming to lectures like this, not smoking, getting depression treated for anyone who has depression. Physical inactivity is very important. Who here does regular exercise? Put up your hand. Okay. I saw not every hand went up. So at any age, you should start doing, they recommend 150 minutes a week of vigorous exercise. And we know this helps prevent dementia. Midlife hearing loss. If you have hearing problems, we know that people who have hearing problems who do not get hearing aids have a higher rate of getting dementia. So get hearing aids, and if you have relatives who need hearing aids, push them, say it protects your brain. It's not just, well, I don't like to have them. It's something you can do for their health. Obesity, we know, causes inflammation in the body, and this predisposes to dementia. So cutting down the calories, it also helps control diabetes. So controlling diabetes, controlling hypertension, high blood pressure, avoid head injuries, be careful crossing St. Catherine Street. People who live very close to highways and get more air pollution have a higher rate of Alzheimer's disease. And then overuse of alcohol and drugs is a factor. Good sleep is important. People should get at least 7 hours of sleep a night. So if you're getting less than that, consider adding sleep. And finally, social isolation. People who are lonely and have less of a social network have a higher rate of getting dementia. And this is something, it's good to come to Atwater Library and come to clubs and interact with other people. This is good for your brain. So these are things that you can address. I'm gonna jump on just for time. We know for each of these a bit about why they work. So for example, physical exercise, again, is good for your cardiovascular health, your blood pressure, your heart, but also has factors that influence the brain and help protect your brain. So it's the sort of the number one thing on my list. Everyone, I'll come back and give this lecture again, and I want every hand to go up when I say, are you getting exercise? We've looked at modifiable dementia risk factors in Canada specifically, and basically what we found was the biggest risk factors in Canada are physical inactivity and not getting enough sleep, followed by obesity, high blood pressure, and hearing loss. So again, physical activity shows up over and over again as the biggest factor that people can address. So I think that's all I'm going to say about preventing dementia, except to say the nice thing is we are hooked into something called Worldwide Fingers Network of groups around the world that are looking on dementia prevention and doing research on how we can prevent dementia. In Canada, we have a group within the CCNA that I lead called Can Thumbs Up, where we're mounting prevention programs here in Montreal and across the country. As part of that, in the next few years, we have an online education program called Brain Health Pro, which is going to be rolled out to the public soon, where you sign up and you get by email once a week a little 10-minute chapter to do on educating yourself about factors you can do to prevent dementia. So dementia prevention is really where it's at in the research world. So when we talk about dementia, dementia is a complex syndrome. This is the lady who was the first patient of Dr. Aloa's Alzheimer's, and he coined the term Alzheimer's disease. She had a variety of symptoms. She had memory loss and trouble with language. This is why we get to the aphasia part. And we do have some drugs developed to treat those symptoms. Neuropsychiatric and behavioral problems occur in Alzheimer's disease. This lady that pictured here, she was yelling and she was agitated and aggressive, and we have drugs to treat agitation and aggression in people. These are a host of psychiatric drugs. But the main problem is a neurological problem, a problem in the brain. And what we do not have, or we're just starting to have, are drugs to stop and prevent the neurological brain damage occurring in Alzheimer's disease. So these are the three kinds of treatments that we have to work on. So what do we do as a doctor when we see someone with Alzheimer's disease? There's a lot that doctors can do. So some people say, well, why even go to a doctor? There's nothing that can be done. But we give a lot of education to the patient and the caregiver. We talk about power of attorney and a mandate, because there are legal questions that arise if someone has dementia. And we look in and discuss with the family about safety, driving, is the person safe at home, and what to do in the future as they lose autonomy. So planning with the family. And there's day programs and respite and social support and monitoring of the caregiver's health, because caregiving is a very strenuous activity emotionally and physically. And in addition, what we do, we give symptomatic drugs listed here, donepezil and rivastigmine and memantine, to try and improve the symptoms of Alzheimer's disease. One which we're using now a lot in Quebec is the rivastigmine patch, shown here, and That way you put a patch on every day so it doesn't cause stomach problems. Interestingly, RAMQ pays for the patch, but in Ontario, OHIP does not. So there's a difference in the drugs available across the provinces. So that's really about all we have right now for treating dementia in terms of treating the disease itself. What we're looking for is so-called disease-modifying therapies. That is, drugs that will attenuate or stop or reverse the disease itself. Now, it's been very hard to find these. This is a model showing a pipeline. So for developing drugs, and this is interesting because it compares the drug industry. The industry average is 4.1% of drugs that they start investigating end up getting to the marketplace. And for Alzheimer's disease, less than 1% of the drugs have made it to the marketplace. So that means it's very hard and expensive to find drugs that work on the brain and for Alzheimer's disease. So this is why we're behind. We're years and decades behind where they are for developing treatments for heart disease and lung disease and liver disease, just taking a long time. Part of this is because dementia in the brain, the symptoms of dementia is not one thing, it's usually a combination. At its most basic level, what we call these neurodegenerative diseases of the brain are often a combination of two things. The vascular and blood flow changes, let's see if I can, there. The vascular and blood flow changes in the brain, and if that's the only problem, we call it vascular dementia. And the bad proteins in the brain, the neurofibrillary changes, if that's all there is, we call it Alzheimer's disease. But most people with these dementias have some sort of a mixture of the two different processes. And this tells you that one of the most important things you can do to prevent and treat dementia is to treat the vascular. That means treating high blood pressure, diabetes, not smoking, making sure cholesterol is treated. Those are right now the most important ways to treat dementia. And this is why, unfortunately, the people who gives you these medications is family doctors. So one of our biggest problem is the lack of family doctors. So, you may know you have high blood pressure, but you need to have a doctor to see to give you treatment. So this is a big problem. Alzheimer's disease itself is complicated. If you ask me what causes Alzheimer's disease, after 35 years in the business, I can't give you a single answer. And that's because we know of different processes in the brain that appear to result in Alzheimer's disease. This one, accumulation and spreading of misfolded toxic proteins. This refers to amyloid and tau proteins. This is where you read about in the news, drugs against amyloid, drugs against tau protein are coming out, but there are these other mechanisms that may also be responsible in some individuals. So because it's so complicated, this has also slowed development of new treatments. If you look in the Alzheimer's brain, as I've said, here's a normal brain with the brain cells called neurons. Here's someone with Alzheimer's disease. You see these funny accumulations called amyloid plaques full of this bad toxic amyloid protein. And you see within the cells tangles, we call them neurofibrillary tangles filled with another protein called tau. Does that mean these are what cause Alzheimer's disease? Well, now we're looking at drugs that get rid of the plaques and drugs that get rid of the tangles with the hope that those will impact and slow the progression or reverse the disease. But there are other mechanisms, as I've said. In our clinical trials unit, we are trying drugs that address each of these different approaches to treating Alzheimer's disease. I won't go through them except to say there's a lot of different possibilities. And so the field is moving slowly. The only one which is coming to market yet is this getting rid of the excess amyloid. And there's two drugs which have now been released in the United States, lecanemab, Leqembi, and donanemab. And if you do PET scans on people before they start those drugs and 1 year later, the people on the medications, the red stuff is the amyloid we can see in the brain. This is a living person going for a PET scan, this one at the Montreal Neurological. And this is on the placebo, there's no change, but on the real drug, the red stuff disappears. We can get rid of the amyloid in the brain. And unfortunately, that doesn't seem to cure the disease. What was shown is that people on this drug, lecanemab, this is over the course of a year and a half. People on placebo, their thinking declines. The people on the drug, they decline maybe 30% more slowly. So getting rid of the amyloid isn't the whole story. So we have drugs to help people, but they're so far not stopping or reversing the disease. But nevertheless, this drug, Leqembi, has been approved in the United States. We're waiting to see if it comes to Canada. In the future, it may require combination therapies addressing, for example, getting rid of amyloid and tau and other things like inflammation and antioxidants. So this is the future of treating Alzheimer's disease. So where does the aphasia part come in? It comes in as a variant of Alzheimer's disease. I'll talk about progressive aphasia in just a moment. What our approach is in my laboratory is to try and use other things, because the neurons in the brain use chemicals, but they also use electricity. So we can try and help the brain by giving something called transcranial direct current stimulation. This is electrical brain stimulation to try and improve brain function. And basically, if in one sense, it's like hooking someone up to a battery and trying to turn on their light bulb. You know, you have the plus, what's called the anode, and power goes into the light bulb and flows back to the cathode. And we can do the same, basically applying a battery that has electricity go at a very low level through the brain. And it's not like shock therapy. The person doesn't move or anything, but and all they feel is a little tingling on the scalp when we turn the machine on. But the electricity going through the brain appears to be very beneficial. And this approach is being used, TDCS, direct current stimulation, is being used by athletes now. As they train, they give themselves electrical stimulation and they do better. It's being used by Olympic athletes. So what we're doing is we develop methods where we are targeting brain areas that we think are not working well. And we're using computer modeling to use a guide to where to put the anode and the cathode and where to direct the electricity. And this is someone with this form of Alzheimer's disease called progressive aphasia. They don't have the whole brain involved with amyloid and tau proteins, but this area on the left side of the brain, which is the language area, it has proven that there are people who develop Alzheimer's disease and other problems with toxic proteins in the brain, where the proteins accumulate in the language areas and they develop an aphasia, which comes on very gradually. Aphasia is a problem with language, with speaking. And they get aphasia, which gets worse and worse to the point where they can't speak. And then they get other symptoms of Alzheimer's disease. What we are finding is if we can target electricity to this area, we can improve the brain function. And this is the research we're carrying out here now in Montreal. So this is what we're doing. One very attractive thing about this is if it works, people can go and buy the machine under their private insurance, or it costs about $800. They can get the machine and use it at home because it's very easy to use. It's quite small. And we have patients who we saw here in Montreal who live in Lachute or Rimouski who have taken the machines back and they're using them every day. So we think this has the possibility of scaling up for the full population. So right now in my laboratory with my associate, Dr. Tyler Roncero, we are trying this transcranial direct current stimulation in various neurodegenerative diseases of aging. These are all diseases that come on with age and affect different areas of the brain. Our main focus is this primary progressive aphasia, but we're also trying in these other conditions, including mild Alzheimer's disease, where we're targeting the memory areas and the frontal lobe, where we call it executive function. And we're seeing if we can improve the function of people with these diseases, experimentally and then roll it out for the medical community. And basically it has no side effects, so this is a very attractive way to try and give new treatments. The primary progressive aphasia I'll talk about in the rest of my time. We've shown that this works in small groups, and now we have a large trial funded by the National Institute of Health in the United States with ourselves and other centers in the States to be the first of its kind to prove that TDCS can help patients with progressive aphasia. So our laboratory focuses on trying to find the variables that matter. How do we improve skills in people with dementia or progressive aphasia? How do we tailor it for people with dementia? There are different aspects such as attention and arousal and physiological states that make a difference. Different participant ages and genders may make a difference. Genetics may make a difference. So we're trying to figure out who benefits from this treatment. This is our focus. What we found is it makes the biggest difference if you're giving the electrical stimulation for half an hour or an hour while the person is doing training. So they don't just sit there, they have to do something. Compared to a sham stimulation, we have people naming things. They name pictures. They look at a picture of a camel and they try and say camel, and they're trying to do language tests. And we find that after we do this for 2 weeks, saying it about 10 times over the course of 2 weeks, an hour each, that people who were on the sham, this line, didn't really change. In fact, they might have got a little slower. Excuse me. Whereas people getting the real stimulation do much better. They're faster and they're more accurate. And this benefit seems to last for weeks. Where do we give the stimulation? We know that the brain function is decreased in certain brain areas in progressive aphasia, usually on the left side of the brain, because that's usually where the language function comes from, is the left side. So we can target, this is a PET scan showing the brain area that's not normal in these patients. So we can target the areas of the brain that are not working well, give them electrical stimulation while the person's doing language tasks, and at the end of 7 or 10 sessions, we see improvement. So primary progressive aphasia is a degenerative disease of the brain. The main symptoms are language problems, not memory, and they just get worse year by year, and they end up having a general dementia similar to Alzheimer's disease. So sometimes it's called a non-typical or atypical form of Alzheimer's disease. And there are many people out there in Montreal who have been diagnosed with this condition. This is one of our first studies. We compare people before and after the rounds of stimulation, how they're at 2 months. They come in for 11 sessions where we do a baseline evaluation, and then we give them daily stimulation of their brain with TDCS while they're naming pictures. Then we reevaluate and we see them for follow-up. And the benefits seem to last about 2 months, and then their language falls off again. So we've been quite successful with this, and now we've tried different areas of the brain and different kinds of progressive aphasia, because their PPA, progressive aphasia, has 3 main variants. So we've had to test all of these, and we test different parts of the brain, stimulating here in the parietal lobe versus stimulating here in the frontal lobe. So we're getting a good sense of who benefits. And basically, we can show, we know we get the maximal benefit over the parietal lobe, and we know which patients benefit the most. So now what we have is this large study funded by the National Institute of Health. It's the first of its kind in the world. We have colleagues at Johns Hopkins in Baltimore and University of Pennsylvania in Philadelphia and Baycrest and McGill. So we're enrolling patients, targeting individuals with primary progressive aphasia, but we're also getting people in who are normal controls, who come in for an assessment, and that way we can compare with normal people as well. And we're trying to prove that this can be used as a medical therapy. And this just shows, basically we're taking people age 50 to 90. They have to be proficient in English, but we are looking for people who are also bilingual to see if they benefit more. one of the reasons we're running this in Montreal is to see, is there an impact on bilingualism on the therapy? This is a big area of research in language. And they have to have a diagnosis of progressive aphasia and able to understand what we're doing. And basically, we have to do an MRI scan, so anyone with a pacemaker, we can't really take in the study. And basically, we do language testing. I won't go into this, before and after the therapy. And they come in for 3 weeks and they get the TDCS about 10 times over the course of 3 weeks. An evaluation before, evaluation afterwards. And some people are getting the real treatment. Some people are getting a sham treatment. And then a couple of months later, we reverse. So you get the sham or the real treatment so people can be compared to themselves. And this way, everyone is getting the real treatment, everyone's getting the sham, so we can prove that it's not just coming in, it's not like a placebo effect. We have to see that the treatment really works. So we're doing this, the treatments, they've given us space in the Jewish General Hospital, actually out at CLSC René Cassin out in Cavendish Mall. So that's nice because there's parking. And we do the testing there and the retesting and the follow-up. We're sending people to the Concordia Perform Center to get an MRI scan so you see what their brain looks like. And then we're taking some blood testing from people and keeping it in these freezers to evaluate later. And so we're getting controlled people to come in and do this as well. So if you know someone who's between age 50 and 90 who might want to volunteer to be part of our study, you get your MRI scan done. That's sort of nice. So our goal is to get 20 people in Montreal with primary progressive aphasia, along with people, 10 normal controls, and we're after bilingual people, as well as unilingual English, and we test them at 1 month and 2 months to see if the treatment has really helped. And this is a 5-year study, which hopefully will prove we have a new treatment for this untreatable neurodegenerative illness. So this is basically what we're doing here. And I put up here, Shelley has this information at the back, a phone number, email address of our coordinator at the Jewish General, and a phone number and 2 emails of anyone who's interested in getting involved in this. And for people who are watching this virtually, write down the email and the phone number, and otherwise you can get it by contacting us or asking at the back. And that's really all I wanted to say today. I hope you've been stimulated. That's a pun.